Welcome, everyone, to the Hemophilia Council of California's webinar, Pharmacy Benefit Managers, Evolving or Disrupting. This is part of HCC's series of patient health access and advocacy webinars. Today, our presenter, Mike Bradley, HCC's president, will cover what PBMs are, what they do, and their impact on your care. I'd also like to thank Takeda and Sanofi Genzyme for their support of our 2019 webinar series.
First of all, everyone, welcome. I know everyone has heard the term PBM, and it's still a mystery to some, and I guess some people actually fully understand what's going on. So my goal today is to give you a very high-level overview of the PBM market, whether or not it's considered evolving or disrupting, and that'll be pretty self-explanatory. Just really quick, a little bit about myself. I'm the current president of the board of directors for the Hemophilia Council of California. Before that, I spent 25 years with Baxter Healthcare, really focusing on advocacy, reimbursement, market access, and government affairs. Before that, I spent 10 years at what was then Children's Hospital Oakland, which is now UCSF Benioff Hospital. And I'm a lifelong Bay Area resident, and I'm very happy to be able to present this overview. So, all right, so let's go over the difference between a medical and a pharmacy benefit, because there are differences, and really what's interesting, and I think that I want to make sure everyone on this call fully understands, is traditionally, and this is when I started, working on this 25 years ago, factor was almost always covered under the medical benefit. And then now we're seeing a slow transition to moving over to the pharmacy benefit. So I just want to make sure everyone has a full understanding. What's the difference between the two? So let's start with, on the left-hand side is the medical benefit. So always in my mind, I always say, okay, it's the hospital or the physician benefit. That's on the medical side. Drugs are typically not self-administered on that side. So, and keep in the back of your mind, does factor fit in? Where do you think factor fits in on this, right? They're typically billed after the service or drug has been administered. So, you'll go in, let's say, to your HTC, you'll go do your comprehensive visit, then your insurance is going to be covered, right? So it's really after the fact. Utilization management is less common, and really utilization management is about measuring how much of the healthcare resources that are being used. Manufacturer rebates are less common. This will make a little bit more sense when I go over a little bit of how the PBM market works. And there's typically a flat copay or coinsurance, right? You usually have some type of out-of-pocket if you go to let's say your physician, or you go to a hospital, ER, et cetera. Switching over now to the pharmacy benefit, in my mind, I always say this is the drug benefit, right? This is the whole drug benefit side. When you go to CVS, or you go to Rite Aid or Walgreens or whatever, and you go and pick up some type of pharmaceutical product, be it an antibiotic or whatever. Typically self-administered. A lot of times they're a pill. They're billed to the PBM by the dispensing pharmacy. I'll go over a little bit more about that as we dive into this. Utilization management is not only commonplace, but it is very, very prevalent. PBMs do a really good job at managing what drug is being used, how it's being used, how much does it cost. There's typically a tiered copay. You've all heard tier 1, 2, 3, and 4. All the way tier 1 is a generic drug. Tier 4 can be a specialty drug. So depending on what drug that you're using, your copay will be altered based on the category that the PBM puts that drug in. And then manufacturer rebates are quite common. Once again, the only reason I bring this up is once I go over a little bit about more detail of what PBMs are and how they work, you'll understand the manufacturer rebates play a big role. And any of you who have paid attention to this in the news lately, this is the biggest thing, right? You got high drug prices are in vogue right now on both sides of the aisle, but the drug companies are blaming the PBMs, and the PBMs are blaming the drug companies. So hopefully after this, I'll give you a high-level overview so you can put everything together a little bit more. So what's a PBM? So PBM, Pharmacy Benefit Manager, that's what it stands for. In a nutshell, they manage the drug part of your health insurance. So, let's say when I worked for Baxter, I'll just use that. We had a number of health insurers that we used over my career. United Healthcare was the last one, but our PBM was Caremark, CVS, right? So I had an insurance that was United Healthcare, but really my PBM, who managed the drug side of everything, was really a different company that was contracted, and then that was Caremark or CVS. So they contract with insurance companies or employers, right? So Baxter they're self-insured, so they would go and they would sign contracts with these PBMs to manage the drug benefit. They manage the drug benefit, the prescription drug benefit for employers, health plans, third-party administrators, etc. So once again, these can be independent companies. Now more and more, they're actually affiliated with health plans, but they're actually contracted by either your employer, right, or your health plan to actually administer the drug part of your benefit. They manage the formulary. I'll go over a little bit what a formulary is. This is a high-level formulary. It's basically a list of drugs that your health insurance is going to cover. They create client programs, negotiate discounts, and then contract with pharmaceutical manufacturers. I'm going to give you really soon an overview how everything ties together. Hopefully, it'll become clear, but it's very complicated, so I'm going to try to simplify it as much as possible. And they offer disease management, especially medication management and drug utilization review. Many of them have a mail order pharmacy, so many times now, instead of going to the drugstore to pick up your prescription, you can just have it delivered directly to your home, which is a big part of what the PBMs have transitioned into. And then they manage the pharmacy network, right? So depending on your insurance, sometimes you're not able to go to every pharmacy to get your drug. Sometimes you can. Sometimes it's an open network. Many times it's closed, right? And so these PBMs sign contracts with your health plan to have certain network pharmacies that you can supposedly get better pricing if you go to that. So what are the responsibilities? I already brought up they operate mail order, right? They ensure patient compliance. That's a big thing. Is that's part of the management part. Is if they send you a drug and the insurance company is paying for it, they want to make sure is that you're using it, so that you're being compliant to the therapy that has been given. They manage distribution. I discussed that already through the network of pharmacies. They negotiate rebates. Once again, the rebate comes up. They process claims. PBMs originally started as just processing claims, right? So, you'd go in and you'd have to fill out a claim form, or you wouldn't, or someone would, your doctor would, and fill out a claim form to send to your insurance. PBM started that way, and then now they've branched out to actually managing all aspects of the drug benefit. And then they manage the formularies. For factor, formularies have not been a big issue yet. Most of the time, all factor is covered. I'm not going to be going over that in this overview, but that's something from a bleeding disorders perspective that everyone puts on their sites to what the future is going to bring. My guess is that some of these insurers are really going to start focusing on the formularies. This is the pharmacy supply chain. So I just want to give everyone a caveat. This is not necessarily the same for factor, even though factor is kind of close. This is the bulk of drugs, and let's say it's a pill. So let's say you're taking a pill for arthritis or stomach problems or whatever. This is pretty much how it works, and this is where the pharmacy benefit managers have really played. But I want to start with the drug maker. All right, so the drug maker is going to make the drug, and they're going to sell it to a wholesaler. And this is where it's different for factor, because most of the time factor doesn't have a wholesaler, right? So the drug maker will make the drug, they'll sell it to the wholesaler. The wholesaler will then negotiate a price with the pharmacy, right? So for factor, it's usually drug maker, wham, goes to the pharmacy, which usually is a specialty pharmacy / home care or an HTC. All right, so once it's at the pharmacy is going to dispense it, right? Whether you go to a store, you get a mail order, they drop it at your house, whatever it is, the pharmacy is going to dispense it, right? And that's where you all come in right now. If you're a consumer, then what you do is you're going to pay your premium to your health insurer, right? And so on that's pretty clear cut. I think everyone kind of understands drug maker, wholesaler, pharmacy, shipped to you. Your insurance is, you got to pay your insurance. Now, where does the pharmacy benefit manager come into play? All right, this is where it's going to get a little confusing. I'm going to try my best to do this relatively quickly. So the PBM is going to negotiate with your pharmacy. Let's just say Rite Aid, right? So they're going to negotiate with the pharmacy over what the drug is going to be reimbursed, right? So where the drug maker is going to sell it, this is all about how much the pharmacy is going to get reimbursed for that drug, right? And this, once again, is the pharmacy benefit manager has been given this task by your health insurer to manage the drug benefit, right? So then how does the PBM actually make their money, right? So there's two things. The PBM is going to negotiate to receive rebates from a drug maker. So many times a drug maker will want to get preferred status on a formulary, right? So what they'll do is they'll negotiate with the PBM to say, okay, I'm going to give you a certain percentage in a rebate so we can be your #1 asthma medication or diabetes medication or whatever, right? But at the same time, the insurer or employer is going to pay that PBM to actually manage the benefit, right? So you're going to be paying your premium here. Your health plan is going to contract with the PBM. They're going to pay a certain rate, right? But at the same time, the PBM is getting a rebate both from the drug manufacturer and possibly even from the health insurer. But most of the time, what the health insurer is going to do is to say, okay, PBM, you're getting this money from the drug maker. We want a cut of that. That's the best I can do in this short of time. I just want everyone to understand in the news, what you're all hearing right now is, are high prices of drugs, are they the fault of the drug maker, or are they a fault of the PBM, or is it both, right? Because what the drug makers is doing is, they're selling it here, but at the same time, they're actually providing a rebate. So there's all these parts that are getting a certain cut of the profit, and everyone's blaming each other. But, all that we know in the United States is our drugs are likely the most expensive in the world. And it's just mainly because you got this supply chain that I know is still confusing to some of you here. But I think if you really look at this graphic, if you have more time, and it's going to be on our website, you'll get a better understand that, what, it is unique in the United States. There's a lot of people taking cuts of the profit. And eventually, something's going to have to give just because the prices are too high. All right, I'm going to go to the difference between drugs and specialty drugs. And I put this under here is, why is the definition so confusing? Because I want to let everyone flat out know there's no pure definition of what a specialty drug is. I'm going to show you 2 slides from 2 different sources that will outline what a specialty drug is, and they are different from each other, but they are similar at the same time. So what is a specialty medication, right? And in my mind, I always think if you're taking a pill, most of the time that's not considered specialty, right? That's just considered a drug. So in this definition, and this is from a health plan, a specialty drug is considered used by a small number of people, treats, and once again, think hemophilia, whether or not this fits into this category. Used by a small number of people, treats rare, chronic, potentially life-saving diseases, has special storage or handling requirements, such as needing to be refrigerated. It may need close monitoring, clinical support and management, and complete patient education and engagement. It's a high-cost medication, may not be available at retail pharmacies, maybe an oral, injectable, or inhaled. So when I go over all these, I think Factor ticks every single one of those, right? Hence why Factor is a specialty drug. Before I go over to the next definition, just a little bit of history. When I first started, when I worked at the HTC, that's when monoclonal plasma product first came out. Back then, there wasn't a whole lot of specialty drugs. Factor was one of the few specialty drugs that ticked every single one of these, right? Now there's thousands of specialty drugs, and this is why the payers and the PBMs are focused more on this category. This is another slide, got it from a different source. Once again, think in the back of your mind, how does Factor fit into this? And then how does non-Factor fit into it? Or how will gene therapy fit into it? I mean, the hemophilia market, bleeding disorders market is changing. Treat a chronic complex disease. Require greater number of clinical monitoring. Have limited supply. Require additional patient adherence and compliance monitoring. Need coordination of care and supplies. need training and support for drug administration, be subject to wastage based upon individual dosing or due to manufacturer packaging, and then frequently cost over $600 prescription. Once again, factor ticks all these boxes. And if you go to the right-hand side here and you look at the purple part, there you go. Hemophilia is right there, right? But also immune deficiencies there. So you can see now, and these are just broad categories, right? There's tons of asthma, there's tons of cancer. I mean, you know, hemophilia is now still considered a specialty drug, but not necessarily, it's not unique anymore.
And so thank you everyone for joining us. We went long, but Mike had such great information that I hope everyone got a lot of great tidbits out of it. I know I was scribbling down notes throughout the whole thing. And I'd also like to again thank Takeda and Sanofi Genzyme for sponsoring this webinar series. And you can find information on our upcoming webinars on HCC's website. We'll be opening up registration for our next 2 webinars later today, so that we can we don't try not to confuse people by putting up registration for multiple webinars at once. So I hope you can join us for those. Thank you very much.